It's over here. Okay, trust me. I gotta learn to be flexible. I'm gonna have babies. Okay.
We're live.
Okay.
Hi, guys. Chelsea here. I am so excited to have Emily with us to talk about burn nursing and all the things that she is passionate about with burns. She's been a nurse for 9 years and currently going back to school for her MSN and BSN. She's a crazy lady. I'm so excited for you. What did you say?
MSN, but yeah.
Oh, I said BSN. I'm sorry. BSN FEP, right?
Yes.
Okay. All right. Good. So, you've got school, you've got lots of other things on your hands. So I'm super excited that you took some time to Facebook with us and talk to us about your experience in burns. I will say, guys, that I am virtual schooling my kids right now. Okay. So if a little person happens to walk in the room and ask me a question, ignore it. I'm sure many of you are experiencing the same thing, and I apologize. So Emily, please introduce yourself and tell us about your passion for burns.
Okay. Well, it actually started in high school. I have a family member who's pretty big in the burn community, and so he actually asked my mom if I'd be interested in shadowing him for a couple of weeks out in Ohio, and that's kind of where it started my passion in pediatric burn. And then I had the opportunity to do a capstone in college in Syracuse's burn unit, which I loved, and then kind of just continued. I was actually offered a job in a burn unit the day I graduated or finished classes in nursing school. And I've kind of run with it since. It kind of runs in the blood. So, yeah, I actually thought I was just going to come out and do regular ICU, and then fell in love with burns, and hope to get back into it after I finished school, and probably both the RN context and the master's. Thank God we're able to kind of go back in and forth.
Yeah.
So yeah, that's where it kind of lies, and I've had the opportunity to work at very established burn centers, so I've been very fortunate, and then also to have the family member kind of be my mentor through the whole thing as well. So
what an amazing opportunity to be able to shadow as a high school student. I mean, how amazing would that opportunity be for all of our high schoolers? Is there any opportunity in terms of young students who aren't sure where they want to go? Would you recommend that type of experience?
So I actually am realizing now. So it was actually college, but in high school I actually had the opportunity to do some ER and trauma. So kind of have that firsthand step into it. I think it really shows you, you have so many people who start out nursing or want to be nurses and then see blood for the first time or a wound or whatever it may be and change their mind. So I had actually had my heart on ER and regular ICU, and then in college had the opportunity. I think it's really great to have that exposure. If you have the ability to do it, I feel so fortunate. I really had those 3 weeks. Well, it was 4 weeks. I actually did 2 weeks with him and 2 weeks out in an adult unit.
Okay.
And I learned a lot. So I think it's really valuable. And I think the best thing is to network. And as nurses, we need to support each other. So if you have a friend who has a kid and you have the opportunity to help them get into one, I think that would be great. I think it's really important to pinpoint early on where our love for our specialties lie. So.
Sure. And so much talk goes on about whether should I do 1 year of med surg? Should I do 1 year of X, Y, or Z before you go to where my passion is? And my own personal experience is no. So many nurses burn out because they're so busy trying to fulfill some, I don't know, rule of thumb that says that we have to do whatever it is. And it really is about pursuing your passion first, which leads to less burnout and more job satisfaction.
Yeah, I mean, while we're on that, I have to tell you, I had a lot of family members who are also medical and said, well, do a year of med surg and do a year of ICU. And
yeah,
I went straight out into pediatric burn ICU, and like one of the top, there's 4 children's burn centers in the world. And I had I thought it was the best experience. I thought to come out and get your knee deep right into your specialty. So, everyone has their own, I would say, protocol, but it doesn't always match. So.
I agree. And some institutions require that you get some sort of prior experience, but you just reach out to them and ask what that looks like. And those units that require that going in, they have a partnership with, say, that med surg unit or whatever it is, cardiac step down before you go to cardiac ICU. They have those relationships. And so that is known that you're going to start there before you move on to the cardiac ICU. But I'm pretty sure that the med surg feels like the redheaded stepchild of all specialties, because they truly are a specialty. I don't know about you, but there's no way I could manage 8 patients at one time. Like, I'm an ICU nurse. I don't know how to do that. So it's a true work of art for all of you med surg nurses. We're going to talk about this in 2 separate pieces. The role focus is in terms of what exactly does a nurse in a burn unit do. And then patient-specific focus, more about treatments and the types of patients that are seen on a burn unit. It's not just, oh, I got burnt by a fire. There's so many things that get to be classified as a burn patient, right? So we're going to talk about those 2 things. So let's start with role focus. You already told us about when you kind of decided that burns was your passion, but did anything in particular prepare you to work in the burn unit? It sounds like you started there as a new grad, correct?
Yeah, I did, but I had I would say probably with the experience I had before, I would say somewhere between 7 and 8 months of exposure. My clinical capstone in college, I was very fortunate to have a wonderful preceptor, and she really put me right in there. So I really came out of nursing school. It wasn't just the clinical for me. I really was knee deep. I will remember those patients forever.
Yeah.
I mean, I was doing burn dressings. I was helping manage the vents. I was, so. Yeah, so I'm sorry, I'm gonna go back to, I lost track of what was the original question?
You're fine. If something that you did prior really prepared you, because one of the students Ivan's a student. Ivan wanted to know if you felt like burns is a good place for a new grad to start, or if you recommend something else to kind of lead that way.
I think I knew, so when I had the opportunity to shadow and do my clinical, I knew from the get-go that this is what I wanted. I think if you are a person who knows that burn nursing is your thing, I mean, for me, it runs in the blood. I will never, it's my thing. I plan to go back to it.
Yeah.
But if it's just kind of like I don't know how to say it, kind of like a moonlighting position, kind of where you're only going to do it for a couple of years, I wouldn't start out it right away, because the skills you learn in burns are very, very different. I mean, obviously some of those nursing skills, but the critical care and thinking skills very much differ between regular ICU and burns. You're managing fluid counts, something that you don't necessarily learn in regular ICU. So the answer to your question is, if you're planning on making it a lifetime, for sure. If you're not, I wouldn't. I would start in a regular ICU. I would get that exposure. It's kind of all where your passion lies. I came out from day one. I want burns. I want pediatrics. I, thank God, got exposure to adults as well. But I still remember, I'm thinking of the story, when I was in college and took care of a pediatric burn patient for the first time with my family member. And it was just very hard. It was very emotional. It was very tough. But I knew even through the tears that it was what I wanted to do forever. So it's a very specific specialty. It's more specific than labor and delivery. It's a very, very specific thing. And I think, for example, if you have labor and delivery nurses who know that's what they want to do, yeah, that's where you start. But I think it just depends. But if you have the passion, go for it. You'll learn a lot. You learn a lot about yourself as well. So,
As is in all parts of nursing, right? We all learn so much about ourselves too.
For sure.
So say there's no burn positions available. Where would you recommend someone who says, I want burns, at the end of the day, I want burns? Where would you recommend that they start to get some foundation? Is there any one place in particular, if you could say, well, if you really want burns and there are no burn positions, maybe you can try this as a nice segue?
A lot of hospitals have trauma step downs or trauma ICUs, and I think that would be a good place to start.
Okay.
I also think wound exposure is huge because you're going to be knee deep in that every day. So I would say I wouldn't do like a regular run of the mill ICU. I would try to do some trauma ICU, some cardiovascular, get those really deep kind of scary critical care situations, because burn patients go through, sepsis, multi-organ issues, ARDS, things like that. And you want to have, it's not just the dressings and the wounds, it's the deep end of all the things the burn will do. So you really want to have that exposure.
For sure. So I know every unit does the process of training a little different.
Yeah.
What was your process of training like? I know for me, it was 12 weeks going into the pediatric ICU, and not all pediatric ICUs structure it like that. So what was your personal experience, and do you know of any other training structures?
Yeah, I still have to tell you, my orientation was amazing. I had a preceptor who had been in over 20 years of nursing experience. And I had 12 weeks of orientation, and I saw everything from a patient coming in, for kind of burn rehabilitation, so, 3 years past the burn, still doing some graft repairs, or not graft repairs, but reconstructions, things like that, to like a 98%, 99% burn. So I had exposure, they started slowly, right? They're not going to throw you into a 99% burn.
Yeah.
But halfway through my orientation, I was managing a very, very sick patient pretty much by myself. And it was amazing, and I treasure that experience forever. But it was 12 weeks, and then they reevaluate to see if you need more help. And then I started out on nights, so I had a lot of support. That team was amazing. We very much worked together, so I think that that made a huge difference too. The team of nurses, because it's a smaller children's burn hospital, it's a smaller team, so it's a little bit, which is good, I think, because I think as a new nurse, that was huge, hugely valuable.
Yeah.
So yeah, it's about 12 weeks. They did ask me if I felt like I was ready, but by that point, my preceptor was like, "Oh, she's fine. She's ready to go."
Yeah.
So definitely 12 weeks, and sometimes it's 16. It just depends. I had come from burn experience. I think that was partly it. I think if I had come out of nursing school with not really strong clinical experience, it may have been longer. But every nurse has their times, and there's no shame in needing more time or feeling like you got it in 12 weeks, and there's no shame in asking questions. We all just need to support each other, and thank God I had a very supportive environment, so that helped too.
I totally agree that open communication is absolutely vital, and you're going to get the most out of your experience as an orientee if you're being super open and honest. Hey guys, I don't feel like I'm comfortable. And you may get some pushback like, no, you're ready. You're okay. We're here. And sometimes they've done this a while. Most of them, whoever's precepting you, they're going to give you that vote of confidence. I'm right here. I'm not going anywhere. You can do this. And sometimes we need that little push. But if you're truly, as an orientee, not comfortable, communicate with your preceptor, communicate with your manager, whatever that is. Yes. So Emily, I was going to say, if you want to try your computer again, you're welcome to. You would just log in and log out just like we did before. If you want to try that, because I notice your phone keeps falling, if it's driving you nuts, you're welcome to do that.
No, it's okay.
Okay.
My computer's on, so it stays charging. So we're good.
Okay.
We're good.
Okay. Sounds good. So what would you say, are you certified as a burn nurse?
So actually, that was probably a question I was gonna answer. So, I worked for I'm being careful with HIPAA and stuff. So I did work for a children's burn hospital.
Yeah.
I don't mean to be vague, but I'm just, protecting patients and things like that. But, their thing right now is, you get your PDCCRN. And then you can take like an ABLS class, which is basically like burn licensing. They used to have this like a kind of a burn RN certification, but it's not really so much happening right now.
Okay.
Or it's kind of a newer thing. I'm still doing research on it myself. But right now the core is the CCRN. I was going to do it. I unfortunately, actually, after a little more than a year burn experience, had a nearly fatal car accident myself.
Oh my goodness.
Had to take I think I'm fine, but had to take had to take a step back. Don't drive drunk. The guy almost killed me. So anyways, it's okay. You live, you learn. It wasn't me drinking, but you know what I'm saying. You go through that experience and you come out stronger. But so I didn't have enough hours. I'm right now working. When I'm done with school, my plan is to go back and get that. But It's not, I mean, it wasn't required. I think it
Okay.
helps. I think the ABLS class is the biggest thing, and there's a lot of burn hospitals, probably not with COVID so much, are offering that. But big burn units, big established burn units, do offer that.
Okay.
Um, so yeah, I mean, it's valuable. I think the class is valuable. There's a lot of actually the one I took, the class I took was actually offered by firefighters in the area.
Okay.
Um, so yeah, and I can definitely post. I can get the information and post that afterwards, so that way people have that information. But yeah, no, unfortunately my burn career took a little hiatus when I was hit. So,
Yeah.
but yeah, no. So yeah, I mean, it's valuable. I mean, I don't say it's not valuable, but I think a lot of the stuff you're going to learn is going to be more on the job.
Okay, great. And you said you had to have a certain number of hours before you test for the certificate. Well, how many hours is it for burn?
Well, it's the CCRN.
Oh, for the
So
CC,
that's just
right?
a
Oh,
regular, yeah. So it's just a regular, and I have to look it up. The ABLS class you can take at any point.
oh, good. Okay.
And then the burn RN certification, because I actually spoke to my former nurse manager, and he said it's kind of like, it sounds like it's kind of like on hiatus right now. It sounds like they're not really offering a straight out burn certification. But I can also get more information on that and post that as well.
Okay,
So
sounds great. So,
yeah.
what would you say the best part of your job and the worst part of your job is?
Um, let's see. So the best part I think is the reward. Um, I will tell you, like, even over the past 10 years, I could give you the, like, scenarios, the patients I saw. I mean, obviously with HIPAA, I wouldn't, but, those never leave you. I think the worst part is that unfortunately burns higher percentage have a higher mortality rate. So you do lose a lot. And that was the hardest part for me. Losing burn patients that I had taken care of, a lot was very, very hard. It is stressful. I mean, I'm not going to lie. I think I worked in regular, kind of trauma ICU too. And I'm not diminishing that by any means, but I did find that it's very, I mean, every part of it is stressful, but, but it's a definitely high stress environment. There's a lot of lab values you have to pay really close attention to, and a lot more, a lot more if they weren't burned. Obviously. So, when you're looking at burns specific, but definitely the reward and the team that I worked with, I think it was very valuable. You come into burns for a reason, right? Like nobody wakes up one day and they're like, oh, I'm going to be a burn nurse. Like you have a passion for it. Same way you have a passion for geriatrics or labor and delivery or general PICU. I mean, you come with a passion. So, the nurses you work with have that passion too. And I think that's the best part. I mean, I loved it. I think the hardest part was losing patients. It's a. I feel like we always said it's like a valiant effort. You work so hard, but there's only so much you can do. My mom's not a nurse, but she's always been very good at it. I remember she told me one day when I was in nursing school that sometimes your job is to save the patient, and sometimes your job is to let the patient go.
Awesome.
And yeah, and so I think you have to be able to compartmentalize.
Mm-hmm.
I actually saw that there was a question. So I actually figure skate. And I figure skated through my first 2 years of burn nursing. That was how I de-stressed. I would get off of a night shift, go home and shower and change and hit the ice rink. And that was my quiet time.
That's
During
awesome.
the day, this was when people were in school and everything. And so you have to be good at compartmentalizing. You have to having somebody you can talk to. The nurses that I worked with were very good to each other. That was kind of our therapy.
Yeah.
And I always say, if you need a professional, it's okay to go to professional. It's not crossing HIPAA lines. There's somebody there to help you. We were all told from day one, this is very important. I mean, think about the nurses that took care of the 9/11 firefighters and things like that. I mean,
Right.
Nobody was told to keep your mouth shut. Don't go talk to anybody. So that's really important too. Obviously, with HIPAA, going to a professional is okay, and the nurses you work with, going home and giving your husband all the detailed information is not okay. But you need to be able to have an outlet. So
Yeah, I took care of actually several burn pediatric abuse cases. And
Yeah,
those
we saw a lot.
cases, I will never forget those, any of them. There was 4 to be exact, and all 4 of them left a really nasty mark in my heart. And just the whole thing is so traumatizing. I mean, it's one thing to handle a burn, but knowing that it was an abuse issue was just even harder. And I just totally appreciate all of the burn nurses and all the work that goes into it, because burn is so unique. And the PICU that I worked at the time, for 2 of them, we were an all-inclusive, actually for all of them, we were an all-inclusive unit. So any pediatric burns, trauma, anything came to us. And so it was just kind of a catch-all, and we were not super proficient at it. We didn't see it a lot. And so we'd have sometimes the adult burn nurses would come down and give us pointers when we were first doing dressing changes. And my goodness, I can't appreciate you guys enough. That's just such hard work. And the smell really got to me, like, oh my God,
Yeah,
how you do it.
yeah, I've cared for, unfortunately, quite a few abuse patients, and I know the smell. It's funny because at some point when you start burn nursing, you don't even smell it anymore. But the joke was when I worked in upstate, it was freezing, right? So I would leave the unit and I'd throw my North Face on. Well, when I got home over the summer, after I graduated, I brought the North Face in to go get dry cleaned because I couldn't stand the smell anymore. I was like, it smells like a firefighter, like it was that smell. But yeah, and the rooms are also like 80 to 90 degrees. I think I lost like 10 pounds my first year of burn nursing from sweating it all out. But yeah, that's always the joke. When I worked in trauma burn step down and I took care of firefighters, you open up that door, you don't even need to look at their chart. You know it's a firefighter before you even walk in the room. So the abuse cases are hard. I think those were the ones I struggled over. Because to me, it's like, how can you do that? But it's the same way when I worked ER. You see, shaken baby and things like that. It's all awful. But again, it's one of those things. Your job is to take care of the patient. That's your job. You have to leave it, the rest of it aside. And thank God, like, we are all, soon to be or going to be or whatever, moms who care for our children properly. So at this point, it's just the best. We also had a lot of cases where they were moved right into foster care. And that's hard too, because you have to separate the mom from the child, and that's horrible too. So thank God we had CPS workers and social workers that handled that. I don't know what I'm so grateful for all of you. I don't know what we would do without it.
Yeah.
So, yeah, it has its tough days.
So Tara asked, what sort of education do you typically provide to new burn nurses? And I think what she's asking is more specific, like what are the big things that you need to hit on, or maybe education as patients, actually. I'm not sure what her question specifically is. So you can talk about whatever education you like.
Okay. Well, I think the big thing, like I had talked about before, is that ABLS class.
Right.
I think getting an idea of burns. Obviously, you have that Parkland formula with the fluids, which the physician's going to handle. But it's always good to know. I'm not saying don't know it. I'm saying, that's like not usually our call. But so this is kind of where the thing. I mean, every burn center in the country has their own technique in terms of their protocols.
Sure.
For what types of debridement, what types of dressings, what type, I could go on and on. Being that I have a family member who is well respected in the burn community and is very high up there in terms of decision making, I got very lucky that I was kind of given that like behind the scenes. And what he told me is that it's very important to be in a burn center with a physician who's been doing it for a long time, because you're going to learn evidence-based practice. There's new things every day that come out about burns. There's it's like that with nursing, right? There's new things all the time.
Yeah.
So I think in terms of education, I think a burn class is great. But really, it's that orientation. It's that unit specific, because one unit will use this for a dressing and the other unit will use something else. So I can't really, there's not like, okay, and I'm just going to use the labor and delivery example. I'm not trying to pinpoint labor and delivery nurses, but obviously there's a specific, OB has its own physiology. There's a specific thing of how things work and medicines and things like that. Burns is not like that at all. There's changes all the time. There's newer research that comes out, and I mean, thank God, right? Because as nurses, we learn when there's new research, new case studies. So To answer your question, because I know I'm being all over the place and I apologize, but I think a very good orientation from a reputable burn center and a burn class. I think that would be it. And anyone's more than welcome. If anybody has questions to message me, I do, because I've been immersed in all this with my family member, I do have familiarity with kind of which burn centers, because some of them obviously are newer and they're smaller and they're still learning. And so that would be where definitely to go. But your orientation on the unit is going to be the most valuable thing ever.
I'm just going to add in that there's always new evidence-based practice and standards coming out with every specialty, whether it's delivery or pediatrics or whatever it is. Like, nothing's cut and dry. We're constantly learning and developing, and
there's I meant that. I just meant that with burn dressing, evidence changes by the week. Like, there's one unit will do something for like 3 months and then they'll realize that's all I meant. There's just so much change. So
right. So what's your favorite tip and trick in the burn specialty as a whole?
Tip and trick. So the hospital I worked with, we did twice a day dressings. And they did, or no, maybe it was once. That's been so long, sorry. But we actually did early morning burn dressings. And honestly, I mean, just like any with nursing specialty, it was always time management, right? Get those pain meds into them, get that dressing done, because those mornings are a tight schedule. They had the hospital I worked with, in order to avoid every doctor for the rounds going into every room, they used to take photographs. So you'd have the photographer come in, photograph the burn. So you'd essentially do a dressing and have to undo part of it so that the photographer could take the picture, and then, and it reduced infection and things like that, because there wasn't 7 doctors walking into every room every day. So it was really time management, knowing that by 4 a.m. you need to get the pain meds and start the dressings and, removing because the whole process. So I think it's really time management, being familiar with the types of dressings and asking for help. I mean, for me, that's really what it is. It's asking for support when you need it. I'm trying to think tips and tricks. I think the other part of it is fluid balance. I learned from day one about kind of how to check a patient's fluid balance, because you can dehydrate a burn patient without even realizing it.
Yeah.
So I think those are the types of things. Like, if you were to start an orientation, I would say, find out what their dressing protocols are. Find out what their fluid protocols are. I mean, they are standard, but you know what I'm saying. Make sure you know what to be looking for, and what they're kind of scheduled, because every unit does things differently, so that's kind of really important. And it burns, it's hard because it's not just the medication passes and things like that. You could be managing a dialysis machine, you could be doing Q15 ABGs, you could be doing burn dressing, so there's going to be a lot. And asking for help is probably the number one tip. Don't ever go in, like, if you think it's going to be too much, make sure you ask, because your team's supposed to support you. So I would think those in terms of the things I could remember. So, and I just want to say, I was not like trying to be mean to L&D nurses. You guys are incredible. I was just explaining that burns is just very unique.
Yes, and that's great. I just wanted to make sure that I laid it out there that I'm very well aware. You put me in L&D and I would have been like, what? So
let me tell you, I couldn't do it. There's no way.
So Mary wanted to know what your most memorable wound was and how the treatment process went.
Okay, so these are one of these questions where I'm not going to get too specific, but we had a very sick patient, let's just put it that way. So I think that one's probably the one that sticks out on me completely. I've actually had 2 or 3 very, very, very sick. Unfortunately, there was different outcomes with them all, but it was an orientation, and it's like, you're managing, there's so much you're managing the vent, you're managing the feedings, you're managing the burn dressings, you're managing their blood pressure, you're managing, and for me,
more about the wound treatment is what wounds. No.
Okay, yeah. Okay, so that one was intensive because it was a high percentage burn. So, you're doing, that was about, I think it was like a 3 times a day burn dressing change.
Okay.
Because it's definitely more intensive. I'm trying to think, and labor intensive. And it's hard. Again, you're in a 90-degree room, So I think for me that was probably my most memorable because those dressings take a long time each, and it's 90 degrees in there, and it's emotionally taxing. So for me, I think it was the higher percentage burns, just in general. I would say
Right.
with more dressing changes and more management. So
For sure.
yeah.
So Layla asked what treatment regimen your facility uses most frequently.
Um, okay, so again, my first burn nursing position was like a long time ago, but they so things have kind of changed actually since then, and I actually touched base with the nurse manager because I was curious about the changes. My husband's military, so we moved, so I'm not there anymore. Um, but we used to use a lot of the silver sulfidizing, the
Yep.
cream, and actually they're starting to go away from it a little bit just because it can actually cause blood cell changes. Um, but we used to do that. Mepitel and Mepilex are a huge one. And then they were actually, they used gauze, and then I'm blanking on ace bandage. And that was a huge one for burns. I mean,
I used to use a lot of Aquaphor. Did you guys use a lot of Aquaphor before you put the gauze on?
no. So the typical standard of practice for Aquaphor is on burns that are nearly healed.
So we did the Meplex and then put the Meplex, put the Aquaphor on the Meplex, then put the Meplex on the burn, and then wrapped it.
Right. So that wasn't standard of practice. And right now, yeah. So again, every unit's different.
Right.
But no, it was really just the silver cream, um, and then they used to use zero form. Again, like it depends on the patient and thing. Now they're doing, very good debridements, obviously cleaning, and then using Mepitel or Mepilex, and then wrapping. So it's very interesting because I learned from day one that Aquaphor is only to be used on a nearly healed burn as moisturizing for the skin.
Mm-hmm.
And that's always been, I mean, let me tell you, I get a sunburn that Aquaphor goes on. But yeah, so right now it's really the Mepitel, Mepilex. I actually spoke to my nurse manager because I was curious as of, 9 years later, what they use, everything changes. But those hospitals have a pretty much standard routine, and then they do just to add to it, they do autograft, so they're using donor skin from the actual patient. Obviously if it allows for it, depends on the percentage of the burn.
Right.
And then they're using Tegaderm and Mepitel or Mepilex to cover those areas. So, and honestly, like what we had, it worked. We had patients that came out and really did well, so thank God. So
And what was the most common use of debridement? We used to use Norsen. Is that something that's still used now?
No, and the thing is because I'm talking about my experience, I'm really like kind of focusing on the pediatric end of it, but we really honestly would give the patient like ketamine, and then you just like washcloth and hibiclens. If it was a like full thickness, they went right to the OR. There wasn't even any debriding that was done outside the OR. So yeah, I had actually asked. It was actually interesting. I've been doing a little research over the last few days, just in terms of kind of newer updates and things like that, and a family member has been very, very helpful. It's very funny. I was like, I have another question. But that, yeah, no, I mean, that was used a long time ago. And I'm sure, and I know in some units they still do, but we didn't. So.
Okay. There was a few pictures that I posted on
Yeah.
the actual event as just an eye catcher, really,
Yeah.
so that people would see it and be like, "Oh, I want to hear about burns."
Mm-hmm.
That specific burn was really interesting, and I've never seen anything quite like that in my own personal experience. But again, I was in a all-inclusive PICU, so my experience is limited in terms of burns. Have you ever seen anything like that? And could you tell the way, I mean, the article explains it, but could you tell if it looks like compartment syndrome sets in, or what's happening between those images so that we can understand a little bit more of what was going on there?
Yeah, I'd actually have to pull it back up because off the top of my head, I can't remember it by heart. But I just remember I actually was thinking about like electrical burns that I've seen, which
Yeah.
a lot of times do require escharotomies to kind of, the compartment syndrome, which we do unfortunately see a lot of. The hospital we worked in, we got a lot from international patients. So you have kind of like crazy accidents, a patient falls into a big soup pot, or you have someone, electrical. So I apologize. I could pull up back the images, but I was just, in terms of from what I did see, we do see that. I mean, eschorotomies are huge in burns, especially when it's more than a partial
Electrical in
excision.
nature.
Yeah, and
Right.
electrical.
Mhm.
Yeah. Yeah.
So, what were the different types of burns you saw? Obviously, fire and electricity. What other types of burn patients did you care for?
So let's see. So, you get the house fires, obviously. Thermal was huge. And unfortunately, this is when it crosses into abuse cases as well. You have parents who will generally put their kid into, like, foot into a pan of boiling oil, or hot baths. They're not checking the water. And it happens by accident, too. I'm not going to diminish that, but
Yeah.
I guess, we've seen that too. And then, yeah, a lot of thermal and a lot of electrical, but thermal was probably over some seasons about 60% of what we saw. Internationally, people cook in like these huge pots almost, and kids would fall in. So we would see, and you can tell usually when it's, if you look at a patient and you can see like on their bottom or on their waist, you can see where, usually splash marks and things like that. So yeah, thermal was a lot of it. We got some electrical, and then of course we did have the house fires as well.
And what about, so in our unit we would classify, the one was in the longest, I should say. We would classify like those internal chemical ingestions as burns. They were internal burns. Did you get those types of patients on your unit? The ingestion of some household cleaning liquid or a battery. Those are all internal burns. Did you see a lot of that stuff?
Very rarely.
Okay.
I think, yeah, I'm trying to remember. I mean, I know we have gotten a few of those, but the majority was the actual, bad skin, kind of skin burns. Yeah, because that's obviously managed differently. And I think I may have treated one a long time ago, so I couldn't even tell you. But yeah, I mean, also where I was, they also had another pediatric ER, so a lot of times they were managed there, unless it was something that really needed kind of burn expertise.
Oh
This
no,
was
I'm
more,
talking like ingestion burns where their entire esophagus is like gone.
yeah. I mean, I'm sure we've had it. I don't think I had it over that year and a half, and then I took a little break. So, um, yeah, I'm sure it's been treated there. I'm sure. I just, I think it's also the season. The hospital I worked with got, again, a lot from international, so it's going to be season dependent. Um, yeah, it's been a long time. So, but yeah, I mean, I haven't seen it. There's also sometimes the patients were flown in since there's other pediatric burn hospitals, it's also sometimes that they were like helivac or whatever. So, but I haven't seen one of those, I don't think, ever, not bad at least. So
Okay, that's good
yeah.
because those are like some of my very worst memories actually.
Yeah.
Because you can't see it, the patient looks super normal, and inside they're an
No.
absolute disaster.
No, and I would say like we had horrible like smoke inhalation injuries from house fires, which is brutal. I mean, it's horrible, horrible, horrible. Like trying to get an airway. You do a bronch and it's, really badly, horrible, horrible, horrible. So I compare it to that, which
Yeah,
is just,
exactly.
I mean, the problem with burns, and I think this is something I always teach my students, just because they don't look badly burned, right? But if they were in a house fire or had anything kind of like that, you have to check for smoke inhalation. You need to be looking in the throat. You need to be letting the physician know that it's a house fire, because you can die from smoke inhalation
Mm-hmm.
before a burn. So, you can die from both, but smoke inhalation is huge. So,
Yeah, for sure,
yeah.
for sure. So, so there's some questions about the types of treatments that were used, tilapia versus
Yeah.
best home treatment and dressings for mild burns at home. Do you want to speak on any of that?
Yeah, so mild burns at home, I guess it depends on what it is. Obviously, if it's very open, you need to be evaluated. But something mild like hitting an oven, or it happens, right? I know I baked cookies and touched it without realizing it ended up on like a little burn on my forearm. But So the go-to is obviously icing it, right? And then at that point, Aquaphor is very helpful as long as it's not open. And you can actually get prescription silver cream if it's not horrible. Oh, okay. You can actually get some prescription silver cream. I had a friend who had that happen and was able to do it. But I always tell anybody, if it's more than a sunburn or a small burn, go in and get evaluated. Don't mess around. And really, if it's bad, I would make sure you're at a real burn center, because unfortunately, regular docs don't really have that experience. So
Well, I'll
make
just
sure.
say from experience, not every hospital, not every state even has a burn center. So
they don't. But ER and trauma units are usually pretty good about that kind of stuff. And if they need to, they'll refer out, or they'll get somebody who can make that opinion. But I just had a situation where I had somebody posted, and there was a bad burn and was given horrible advice. So so thank God I had a family member who's actually able to step in. They'll be fine. But so I think that's where it's hard, right? Because the burn nurse in me is like, okay, well, this is so. I would obviously you're not going to be in every city where there's going to be a burn center, but a lot of times you can find a trauma doc or somebody who knows what they're talking about, because that's really important. Management of that is really important. But for a mild burn, sunburn, whatever, aloe vera, Aquaphor is huge because it keeps that skin nice and moisturized. We all burn ourselves. It happens. I know I have friends who burn themselves on flat iron and whatever. So and then going to the tilapia skin. So I had this whole conversation with him this week. There are case studies about it. It's kind of like pig skin and cadaver skin and things like that, right? It's all being researched. And again, this is coming from a family member who's very, very knowledgeable, so I'm not making this up at the top of my head. It will never become standard of practice. That's just not how it's going to be. There are case studies, right? I mean, it's being used. I've never used it myself. We used that epithelial skin where they're basically growing skin to place on a patient. It's that is very expensive. So a lot of units don't want to be spending thousands and thousands of dollars on something that doesn't necessarily going to work. It's out there. Tilapia skin is out there. Is it going to be standard of practice? No, probably not. Maybe in some units, but in the big burn world, it's not going to be standard of practice. But it's definitely, again, there's studies every day. There's new research being done every day, right? Like, we used to swear by silver cream, and now there's obviously, it's been this way the whole time. There's been concerns about blood cells. So now but issues with white blood cells and things like that. So now there's moving towards silver containing dressings versus full out silver. So, there's new studies every day. I'll be interested when I finish school getting back in the burn world, if the unit I'm near is using it. That would be really interesting. And open yourself up to new experiences. I mean, if you get the experience to see that's probably really cool. I don't know if I'd want fish skin on me, but everyone has their thing. We use a lot of cadaver skin and things like that. So so for sure. I mean, that's what I love about burns too. So much changes. So.
Yeah, that's interesting. Lindsay said there's a debate amongst my ER nurses here in rural Arizona. We don't deal with the burns much. When we have a second degree or higher burn, we're prepared to transfer to the burn center. What do we do for it? One says a clean sheet and one says to place ice water on the burn. One says silver to the burns. What would you guys do in this case in terms of stabilizing and transferring out?
So if it came to the burn surgeons I learned with, it would be silver. It would be stabilizing, if possible, being able to, I guess, if they're not going to debride, then that's kind of a tough question, right? If they're able to debride, that'd be great, and then cover with silver and wrap and transfer. If they're not able to, then putting the silver on a skin that's not debrided is not going to do much good. So at that point, they would probably clean as much as they could and just wrap up. There's kind of questions. I guess it depends on what availability. Being so rural, silver would probably be good, but again, on skin that hasn't been debrided, that's questionable as well. Because ultimately, you gotta get that skin off for anything to really heal.
Yeah.
That's very interesting. And it's interesting because I was very lucky that I learned at like big burn centers, right? So like I wasn't in a rural, and I'm hoping at some point I'll be able to, right? Because then I could learn and I could educate. But Yeah, I'm not sure putting a sheet on top of that raw skin is a great idea. That can cause a lot of pain. So I think just in terms of protecting, I think silver is probably your best bet. So
And then making sure that they're hydrated before they leave your
yeah,
fluid.
so there's a middle ground, right? So that Parkland formula has to be calculated because you can overhydrate as well.
Yeah.
So getting that fluid calculated, getting the fluid in them, stabilizing the airway. If you need to place an airway, get them on, get them intubated. Don't go straight to a trach unless it's like one of those scenarios. That's a huge thing too, actually, that we were talking about is the question of intubation versus trachs. Every physician's different. The doctor I learned with just intubated. So I actually came out of nursing school with 2 years of intubation experience and no trach experience. I learned that later. But yeah, secure that airway, get that fluid, protect that skin, and honestly get them out as fast as possible. You want them to get into that burn unit as fast as possible. It definitely changes that outcome.
Awesome. So in closing, what are you looking forward to most in your career?
So finishing up my master's, where I actually kind of want to do another specialty, but I'm hoping to moonlight per diem as burns, and my also plan is to go back and do some pediatric acute masters so that I could go back into a burn unit as a nurse practitioner. So, but that burn passion will never go away. So at some point, I'm going to get back into it. Right now, focusing on school and family. My husband's military, so we're getting ready to move again at some point. So kind of preparing for that. So yeah, yeah.
Well, I'm thankful for your service along with your family. I mean, with your husband. It really doesn't just, it's not just him out there. You're doing everything too. So I'm thankful for him and for you sticking by him and supporting him. So
he does more than I do, but I said he does more than I do, but thank you.
No, you're supporting him, and all of our service people, they need the support, and so I appreciate it. So thank you so much for tuning in with us. Good luck with your masters, and I look forward to hearing what you do with it.
Thank you.
Have a great day, guys.